disease. I am the Lord, your healer.
Hey, now you're there. Yes,
This is His word. I am the God.
Hey, now you're there. Yes,
that healeth thee. I am the Lord, your healed your disease. I am the Lord, your healer.
Hey, now you're there. Yes,
This is His word. I am the God.
Hey, now you're there. Yes,
that healeth thee. I am the Lord, your healer. And I sent my word, and I healed your disease. I am the Lord, your healer.
Good evening, precious ones.
It's His promise.
This is CCR Ghana Online Radio, and you are welcome.
Psalm 107 verse 20. He sent His word.
To our health, our life.
The Bible says His word will not return void, but it will accomplish the purpose for which it is sent. God's word in the name of Jesus is more powerful than cancer, heart disease, or any disease that you can name today. So let's put His word on our lips and let His healing come to us as we sing it to Him. You are the God that healeth me. Let His healing come as we sing.
This is my health, my life.
That healeth me. You are.
We thank God for giving us such an opportunity to know more about our health. God desires that we live well, healthy, so that we can worship Him, we can know Him better. Not in that state where we are not healthy and always crying for help.
You are the God that healeth me.
And so from today, this Monday, and be expecting that every Monday at 6 p.m. we shall have medical officers here to give a free teaching on our health.
You are the Lord, my healer.
One beautiful thing you need to notice that we are allowed to also bring in our questions, tell us your problem, and these wonderful doctors will help you.
You are the Lord, my healer.
And so this evening we are blessed to have our own precious Dr. Irene Prah with us. And you shall hear from her very soon. But before then, listen to this.
You are listening to CCR Ghana Radio. To support or sponsor our radio programs, please call +233 555 554230 or email ccramat@gmail.com. You can also donate to help us raise funds for our expansion. You can donate via MTN mobile money number +233 555 554230. You can call the same number for sponsorship and partnership.
Right, you're welcome back. Again, this is CCR Ghana Online Radio, My Health, My Life. And we have our beautiful doctor here. And I always want her to introduce herself to us. We are proud to have you here, Doc.
Thank you.
You're welcome. Doc, again, you want us to know you. Just tell us something wonderful about yourself, because today is the first edition of our program, My Health, My Life.
So my name is Dr. Irene Prah. I'm a specialist emergency physician at the Confanochi Teaching Hospital, Emergency Medicine Directorate. I'm a Catholic, born to two Catholic parents, and then the second daughter among 4 girls. So basically, that is who I am.
Great. Thank you so much for making time with us. We know your schedule, how tight it is. but by God's grace, you are here with us. So, Doc, today is the first edition of My Health, My Life, and you are starting with us. So, we want you to tell us what should we be expecting and what this program is all about.
Okay, so you said something in the introduction that I really liked, that when you are healthy, you are also able to worship God well. So it's something that I also think is true. Whenever I go to the hospital and I see people very, very sick, sometimes it just occurs to me, the first thing that occurs to me is, so I believe that our health is very important. It is also a gift that we have to make sure we keep, make sure we take good care of it, because God gave it to us. Of course, as you grow older, you might have a few aches and pains here, but what we put in our bodies, the things we expose ourselves to, and all those things can be detrimental to our health. So we need to take good care of our health. So basically, the program is just going to be different topics from different specialties. Hopefully, we'll have other doctors who are specialized in other areas of medicine, and then, if possible, even nurses who are also maybe specialized or not, visiting and talking about certain health conditions that are common to us that people usually have questions about. We can also have physiotherapists and nutritionists, whoever we can find, maybe Catholic or not, who can give us some information about our health. So today I just want us to get to know about the different specialties under medicine, so that when they come, we sort of have an overview or an idea about who they are and what they really deal with. So I'll start with the first myth. Every doctor knows everything. It is not true. We all start with our basics. So you go to medical school, there's something general that everybody learns in medicine. And we do that for 6 years, sorry. I did 7 years. Now, some people are even reducing it to 5 years. In the US, it's about 8 years. Because you do your degree 4 years, then you can do medicine for another 4 years. And we have that sort of program too in Kolebu, where people do any degree, maybe biology, zoology, whatever, for the first degree. And then they pay for medical school for 4 years, and then they also become doctors. So Jones, for instance, went through our that 8-year one. Okay. So like I said, we go to medical school, we do the basic 5 to 7 year course. Then you come out, and then you do apprenticeship, which we call the house job or the housemanship, for 2 years. Initially it was 1 year. You just choose 2 specialties, broad specialties, and then you work under them. You learn something like an apprentice before you can go out and do it on your own. In other jurisdictions, it's not like that. In the US, for instance, you finish medical school, you start your specialty straight away. So you are sort of a house officer but specializing. So they don't spend too much time in school. They finish specializing like around the age of 26, 28. For us, you may even finish like 35 or something, because there are a lot of breaks in our system. So after the house job, then you decide to branch out into whatever you want to do. Some decide to remain general practitioners who just read more about, as in you just, their basic training ends at house job. But then they probably work with other people and then learn some skills, but they don't have any certificates. So general practitioners who stay there. So there are 4 main divisions of medicine. We have pediatrics, which deals with children. Then we have internal medicine. Internal medicine are the doctors who deal with, let's say, the diabetes, hypertension, autoimmune diseases, and all those ones. Then we have surgery. And then the surgeons are those who cut people, can be your leg, your abdomen, whatever. And then we have obs and gynecology. So obs and gynae, they deal with anything about women and childbirth. So those were the 4 broad ones that were practiced in Ghana. That's now everybody does house job under. But under each broad one, we have subspecialties where you can train and then subspecialize and train under that one as well. So, for instance, our own Dr. Yabwa is an gynecologist. I don't know what he did his fellowship in, his subspecialty in, but you do the broad, how to take care of a pregnant woman and all that, and then maybe women with what we call the infections, as in Odepu and all those ones, and then the sexually transmitted diseases and all those ones. Then after the broad one, you can decide that you are zoning in on a particular part of that broad topic. So some people just become gynecologists, some just become obstetricians, and then we have those who are just general obstetrician gynecologists. Then even under the gynecology, somebody might decide, I'm doing oncological cases or cancers that have to do with women's reproductive system alone. Somebody might decide that they are just going to do neonatal obstetrician, like as in they are just going to take care of the babies who have not come out yet, something like that. So pediatrics, for instance, that is broadly taking care of children, so you don't take care of adults. Your specialty is just children. Then you can decide, okay, now I'm going to take care of the babies who are called the neonates, who are just 28 days old, or maybe you learn up to 0 to 3 months or something, so you specialize in those babies. And then other people will decide, okay, I'm just going to specialize in gastrointestinal tracts of children. Somebody might say, I'm just going to specialize in diseases of the head, neurology in children, something like that. Then we have surgery, where that's one too. We have adult surgery, pediatric surgery, and then there are those who specialize in pediatric surgery. But then we all branch out. So for my part, for instance, I'm an emergency physician. It's fairly new in West Africa. It's the first in West Africa.
First in West Africa?
Yeah, the training center in Konfanochi is the first in West Africa. There are developed ones in South Africa, but I think in Africa, South Africa, and then ours is the most established. Yes, and then but it's something that developed in the US and the UK. So it has been in the US and the UK for a long time. So
it means that it's not so common.
It's not so common. So Europe, for instance, they have something, but they are now really getting into emergency medicine. So everybody sort of had a casualty where people would go and if there are emergencies, they go to a casualty or they go to the emergency, but they didn't have doctors who are specialized in emergency. So that is what now we are doing in Ghana, because it also came about because of the May 9th stadium disaster.
Yes.
They realized that when that thing happened and they took patients to the hospitals, first of all, we didn't have a good ambulance system. And then when the ambulance system also came and they took the patients to the hospitals, people didn't know what to do with them. Even though they were doctors, people didn't really know how to manage the the emergencies. So it was a mess. People died who shouldn't have died. People who should have been transported were not transported and all that. So it's something that the Americans also noticed, and they put things together so that there's a system where you're able to take care of patients in a systematic manner and all that. So that is emergency medicine. So
how many are you in Ghana, these emergency doctors?
So far, we are 10 years old.
10 years, okay.
Yeah, 10 years old, and I think we've trained about 46 specialists.
Wow. We have just 2 in Ghana, and not in Ghana, in West Africa. In Africa.
No, training centers.
No,
there are other ones coming up, but the very well established ones are South Africa and then here.
And we have 46 in Ghana. That is great. That's a good number to have. Please go on.
Okay. So for every specialty too, we have nurses who support. So we have emergency nurses. In Ghana, we have so even though I'm just giving a broad overview, for those who are also interested in medicine and nursing, this is something for you to think about, and then also some information, so that when you're making a choice of specialty, you can also make that. So we have emergency nurses. So Marie, for instance, was an emergency nurse. Yes. And then So for the emergency nursing too, we have the degree one, and then we have the specialty one, like where we. So it's a college, like our college, where you specialize for 3 years. So they are sort of like nurse practitioners. So when we talk about nurse practitioners, they are people who have higher knowledge, who can actually take care of patients like doctors, but they are not doctors. So you have higher knowledge in a particular area of your nursing career. So they are nurse specialists. So this is new, and also the first batch has come out. The second batch is now coming out. So there's a lot of improvement in medicine in Ghana.
Great.
We have to do a lot. So we may also maybe have somebody like that also come and give a talk or something like that. So for every specialty we have, so for radiology, for instance, the doctors read the MRIs, the CT scans and all that. But then we have the radiographers who actually manage the machine. Then we have also sonographers who can also do the scan like the doctor. But the only difference is that they didn't do the anatomy and all those things, so they can just look at the image as they see it and tell you. But when a doctor who has done anatomy and has done medicine puts the history and all those things together, then they can actually tell you that, oh, maybe this one, fine, the books say that it shows appendicitis, but when I listen to your history and everything, I think it's not really that, so don't worry about it. So that makes it a bit more. So we have the different grades. So for each specialty, we have nurses under them as well. So that comes to the second myth that I want to talk about. Not every man you see in the hospital is a doctor, and not every woman you see in the hospital is a nurse.
Not anyone in white.
Yes. Not
important.
anyone in white or in scrap too is a nurse or a doctor. Because we have different colors of scrap. Somebody might just be a cleaner who is. So people should be careful, because we've had a lot of such incidents in Komfanochi where people are called doctors. They do all sorts of things, and they come and say the doctors took money from me. They did this, but it's not true. So that is also something to know about. So that's the second myth. So to encourage the girls out there too, you can also be a doctor. You don't have to be a nurse. I know certain parents who say things like that because they are not knowledgeable about it. So if you know more, you can also be a doctor. If you are a man too, you can be a nurse. So we should all be encouraged to do that. So after talking about everybody a little bit, I want us to talk about the Komfanochi emergency.
Okay.
At least.
Great.
Just to enlighten people on how the system works there.
Okay.
So when you come to the emergency, first myth I want to clear there is you don't need to know somebody before somebody takes care of you in the emergency.
Okay.
Our system is such that when you come, if you are very sick, we do what you are supposed to do for you, whatever. So the explanation I'm going to give will help. So there's something we call triage. Triage means sorting out. Triage, I think it's a French word.
Okay.
So
when you're writing, you need to take notice of the French accent and all stuff.
Well, so it just means that we sort out.
Okay.
So in the emergency, we don't do first come, first serve. There's nothing like that. You can come at 1 p.m. If you don't get a bed, or you are there, and then cases that are more severe than yours keep coming, and there are few beds, we'll give it to them, and you will have to wait.
Okay, Doc, let me ask a question then. So how do you determine that this case is severe than the others? Especially when you might not understand what is really going in the body of the person.
Okay, so we have a scoring system that we use, and as I said, South Africa is the first most established emergency medicine faculty in Africa. Okay, so ours was started by the Americans, University of Michigan, and then with some collaboration from KNUST, Ghana College of Physicians and Surgeons and all that. So basically, those are the people who have trained us up till now. They have, in the US, they have a different sort of scoring system. But when they were coming, they looked at what is peculiar to us that can really help us to really do our triage system well, because the whites have their common diseases and stuff. There are certain things that are common, but our behaviors and attitudes and everything are a little different as blacks than the whites. For instance, the whites go to hospital early.
Okay.
We have some people we call the family physicians. So somebody like Dr. Space, for instance, is a family physician. So they also learn broad things about medicine. So broader than the general practitioner.
Okay.
So mine too is broader than the general practitioner, but I deal with the emergencies, and then they deal with the family sort of little things that happen to the family. Okay. So everybody has a family physician in the developed country. So when something happens first, you call your doctor. That's what they say, call my doctor. Everybody has somebody they call their doctor.
Okay.
Yes. So sorry, I've lost my train of thought. Yes, so somebody like that, if something happens, then they can refer you, and they can say go to the emergency setting, for instance. But unfortunately here we don't have that. So for them, they go to the hospital early, they are seen early, so their problems don't aggravate quickly. But ours, we do all the withdrawal and those things before we come to the hospital when it is far advanced.
Yeah.
So they needed to use a scoring system that supported the behavior and the kind of things we see in Africa.
Okay.
So we are using what we call the South African triage score. So they developed a scoring system where they are able to tell that, oh, this is severe, this is just okay, can wait a little, this can wait for a long time. So that's what we use. So once you come to Confanoche, the first thing, you go to the triage. For COVID, because of COVID now, we have pre-triage before we do that triage. So pre-triage, you come, we screen you, we ask questions that may point whether you are a possible COVID patient or not.
Okay.
And then, if we think you're a possible COVID patient, we can't put you into the main emergency.
Yeah.
First of all, if you've been there before, you can see that it is quite enclosed.
Yes. Yeah.
It's actually a design for not a design for Africa, sort of. So the ventilation is poor. That's first thing. So we cannot mix you with the normal people. People don't understand when they come, they fight us, but we try to explain to them. So we've created a place where it's more of a COVID place, where we put patients for isolation. But there are nurses there are doctors there who take care of them.
Okay.
You are not deprived of anything. Nobody deprives you of your medical care if we think you are a suspected COVID. Nobody maltreats you. So I want people to understand that one. So that is an isolation. So once you pass the pre-triage and you can enter the emergency, you go to the triage, where we sort out, and we use the South African triage score. So the South African triage score, we have 3 main places that you are likely to go, or 4. So we call them the color zones. Red. If you score red, we use your vital signs, your BP, whether you can walk or not, whether you can talk, whether your heart rate is high, your breathing ability, and all those things. We look at all that. So red means that you are in danger of dying right now.
Wow.
So you have to be seen within 1 minute. There are some people who score red who are probably advanced cancer or something that nobody can save anyway. But all their vitals score them red. So for those people, when you come, we start the history and everything. We may not run around like we do for the person who just fell suddenly and came and is scoring red, because we know that your disease has been there for a long time. Wow. So in the US, for instance, when our white people come, they tell us that, oh, seriously, they haven't seen an advanced case like this, even though it's in the books. Something like that. So for them, a person like that may not necessarily score red, so they don't use our scoring system. So that's one of the reasons why they can't use our scoring system. So red means that it should be seen now, so within the first minute. Then if you score orange, it means that not more than 10 minutes it should be seen. But of course, this is Africa. The system does not work exactly like that, because you might go there and there are so many patients a little over an hour before we see you. But it does not mean that when you come and I'm not seeing anybody and you haven't reached 1 hour, I won't come and see you. I'll come and see you. So in the setting of South Africa, for instance, maybe only 4 doctors are on duty and they are seeing everybody. So when they are seeing people and then somebody comes to say there's a red case or a trauma case, they all rush to the trauma and make sure the trauma person is doing well, and then they can leave the others. So in the US, for instance, I've had my sister who has said that she has gone to the emergency and stayed there for more than 8 hours because her case was not that serious. So they were seeing those who came after her who were more serious.
How the complaint will be in Ghana. So that means that is how come people, you just be there and then you receive because we came here and nobody's attending to us, and so that could be the reason. But Doc, is it not appropriate that this teaching, we are privileged to have you here, probably it could be scored on a board for people to understand that this is how the whole thing works, so people will stop this complaint.
It is there, people don't read it. People, Ghanaians, we don't read. Somebody will be standing in front of you, your name is on your chest and asking you what your name is. We are not observant, so that's one. It's something that people don't do. And even when you've told them, they will tell you. Most of the time when they say somebody has come to see them, but maybe it's a girl, they think it's a nurse. So for them, the doctor has not come to see. I've had a lot of them do that to me. So, and you hear them saying, that is how it is. So, so for the US, for instance, people wait like 8 hours and nobody would. But here, the good thing is that we have a word for red, a word for yellow, a word for orange. So there's a doctor for each place. Unless we are short, then maybe 2 people will be taken care of. So if you are lucky and you go and you are yellow and there's nobody there and the doctor is free, you might even be seen faster than the orange patient. You get it? Because the doctor is localized to yellow. Yes, so he's a doctor for yellow, so he won't go unless maybe orange calls out that they are struggling. They have every right to leave you and go and sort orange out before they come, because they should be seen within 10 minutes. And then we have those who score green. Green means that you have to go to the polyclinic to be seen. You are somebody who can be seen, maybe observed, detained, and then go home, or you can be seen and just go home. A lot of times for that one, we've had people who have come and they have not understood why we should tell them to go to polyclinic and and those things, and they'll be fighting you. But we can't use a humor to just congest the emergency. So we have to do the right thing so that the flow will be quick and we can take better care of patients. And then we have blue. When we say blue, blue means that the patient is dead, brought in dead, or the patient has died. So that is blue. So red means within 1 minute should be seen. Orange should be seen within 10 minutes. Yellow should be seen within an hour. And then green to go to the polyclinic. So basically that's a little bit of teaching for the emergency.
Let me just quickly ask this: can a personality or who the person is can influence the score? Let's say a minister has come to the emergency, and because the minister, even though the case could be yellow, but automatically has to be red to be seen than the others. Can that influence?
No, it shouldn't. But this is Africa, like I said. It shouldn't. So one of my consultants will always say there's nothing VIP about emergency. Personally, I try not to do that kind of thing, but of course, if your teacher comes, if somebody who taught me in medical school comes and he's definitely, but it's not like if somebody is dying, I'll leave the dying person, I'll tell him to wait. Definitely, if the person is dying, you will have to wait. Then I'll take care of the dying person and come and take care of you. And if I explain and you don't understand, I can't do anything about it. But that is what we do. And of course, if the place is not so busy and the people are not so critical, and somebody like that comes, you might even get calls from your CEO and other people who might tell you to take care of the person. But as I said, there's always one doctor in each place plus a specialist who's supervising, or about 3 of us. So it doesn't have to be that we stop taking care of somebody to come and take care of you. No, we don't do that. We either tell you to wait and then find somebody else, or we hand over whoever we are taking care of to another person. So there's nothing like that. So then that comes to another myth. We don't hide beds.
Very important, please.
We don't hide beds. People always say we hide beds. We don't hide beds. We may keep a bed if a hospital has called that they are bringing somebody. It is fair that your mother is sick, needs to be transferred, it is fair that when she comes, there's a bed waiting for her.
Okay.
Because if we don't do that, then the ambulance that comes has to wait for hours. That ambulance may be needed somewhere else. So, and then it is also fair that somebody who is being referred, usually if the person is being referred, it means that it's a critical case or a case that they cannot manage. So the person must come and get care quickly. And when that person comes through, the person is triaged. If you are yellow, you are yellow.
Yeah.
It doesn't mean that because the hospital has sent you, I should be running all around because of you.
Yeah.
So if you come and you are yellow, you are yellow. If you are orange, you are orange. If you are red, you are red. If you come and you are green, I'll tell you are green. You didn't require an urgent referral, and I'll refer you appropriately. So when you come and we think you're an OPD case, we write the consult form also for you to go to the OPD. So if you are confused about where to go in the hospital, you can come to the emergency. We'll triage you, give you the appropriate, the advice, and tell you where to go. So that is not a problem because the triage is open to anybody. So we don't hide beds. You might come and see a bed there. If we tell you there's no bed and the bed is for someone, you should understand because maybe there's an ambulance coming from somewhere.
Oh, okay.
And then one thing we also do is we intentionally, when there's a shortage of beds, we intentionally keep at least one bed for a red patient.
Okay.
In case somebody comes and is dying right now, we can't say there's no bed when stable patients are lying on beds and laughing. So we will intentionally keep one bed for a red patient, so that as soon as they enter and realize that it's a rush case, those who often come to the emergency sometimes see us running with the beds, with patients on the bed, running giddy, we go to red, we are doing this, people are running all over because we know that person and we don't need to know you. If you are dying, you are dying. But if we think it is, like I said, an advanced cancer, advanced liver failure, that nobody can do anything about, we may not run. Do you understand? Because you have reached the end of your life anyway. The disease has gone through its course and it is ending, and it is taking you with it. So you may not see us all over the place, but if we think that, let's say, God forbid, we are having a program here, then suddenly one person collapses, and we go to Confanochi, the person, I've seen that the person is not breathing well, is about to die. That person is a red case. Okay. No matter how many 20 people I came to meet there, they will give that bed to that person. Okay. And we'll run and do what we are supposed to do. In these COVID times, it's a little different because most of the time we are not wearing the full PPE like that. So if we think everything you say sounds like COVID, it will be a bit difficult to see us doing. We try, but before we finish gowning, it takes like 20 minutes to wear all those things. Wow. So things
and the red means 1 minute to attend to the person.
That's what I'm saying. So it may not, and we can't wear it all the time because within 2 minutes we are sweating like a pregnant fish. So it's a bit difficult. So in these times, I would say if you are sick, come to report early. Okay. Because it makes the emergency difficult. You can't also put somebody's child, endanger that person's child because he's a health worker. We've had health workers who have gone to see people. The people survived and they have died of COVID. Most of them, they went to see patients and they got it and they have died. So we also want to minimize the risk of health workers also dying. So I think that in these times of COVID, try and have a family doctor so that you can report early, and then you also come and we take care of you as appropriate.
Before I forget, this whole family doctor, or you will come back to it later, I don't know.
You can
do we have many of these family doctors, or you can just appoint anybody to be a family doctor?
So like I said, we have those who are general practitioners who didn't really specialize after medical school. They sort of act as family doctors, but then we also have a specialty called family medicine that people are training in, like Dr. Nana Ferry, for instance. So he has a certificate that he's a family physician, and they also have a faculty like ours who are training more people. I don't know how many people they've trained so far, how many years they are, but they definitely have more family physicians than we do. Because for family medicine, there's a training center in Kolebu as well, and then Confanochi. So it means that if every year they are churning out 10 each,
yeah.
that's 20. But
Yeah.
for us, it's just our faculty, so maybe 5 a year or something like that. So we have more family physicians in Ghana than we have emergency physicians. So you will definitely find one if you need one. Somebody can refer you to the person. So it's I wouldn't say it's easy to find one, but they are definitely more than emergency physicians.
Okay.
Yeah.
Okay.
So that's what they are hoping to do, that will train so many that it will get to a point where most people have family doctors. So that you don't all rush to the referral center like Confanochi, the teaching hospital. Because when you do that, then you crowd the beds. And we have genuine problems with congestion. So people come and they don't understand and they think we are hiding beds. But genuinely, most of our diseases are diseases under internal medicine or cancer or something like that. So when they come, and then financial issues, when they come, because they are sick, they take a long time before they can be discharged. So it means that they are occupying the bed for a long time. Then secondly, there are also those who come, they are discharged, they can't pay, so they are
still there
occupying the bed. Sometimes in the past, people will take them off and let them lie on the floor. But we have stopped that. So if he hasn't paid for 1 week, it's difficult to collect their bed. When we go to the hospital and there's no bed, for instance, and there's a dire emergency and a red patient comes, sometimes we go around looking for those who have been discharged and haven't left, and we take them off their bed and give it to those people. But it's also not nice because maybe it's not his fault. So you take him and put him on the floor. So those are genuine concerns we have with congestion. So those are the problems that make sometimes causes bed shortage. So if we all also work and pay all our bills quickly,
great,
it will help.
Great. Wow, this is so wonderful. Thank you for sharing. I don't know if there are others to still teach us. If not, maybe I'll have some few questions to come up with.
Oh, you can.
I just want to encourage our viewers. That this is my health, my life. We are talking about having a good health means that you will have peace in life, at least. Now, we've heard about this e-doctors now coming up. I think sometimes in Facebook you see some videos about e-doctors. This, my health, my life. Can we have opportunities where people will call in to talk about their health issues? And
now, the jack of all trades doctors, we don't have that anymore.
Okay.
A doctor that does everything.
Okay.
That seems to know everything. We have doctors who, like I said, the surgeons, for instance, maybe the person may be an orthopedic surgeon, bone, works with bones, then may zone in on only the hand.
Okay.
So the person may just be a hand surgeon. So that person has narrowed their knowledge to a particular portion of the body. So if you cast your eye to any part of the body, we have specialists for that part of the body. We have only breast specialists. We have eye. We have nose specialists. We can have ear, nose, and throat. But then that ear, nose, and throat doctor can decide that I'm subspecializing in just the throat. So for every part of the body, there's a specialized physician for that. So personally, I don't believe in e-health.
Okay.
These calling in and telling the doctor what is wrong with you treatment. I believe that the person sometimes may need to see you.
Okay.
Sometimes may need to touch and see whether it is really the story you are giving really matches what he's seeing. Because those are the things that help us to make a diagnosis. And then you also might need your CT scan, X-ray, and all those things. So for instance, if I suspect that you have a brain tumor, for instance, I may need to look at your eyes to see whether maybe the black parts or the pupil, we call it, one part is maybe more dilated than the other one. So if you call me on the phone and tell me that, doctor, I have a headache, and I say, oh, go and take paracetamol, have I done you good or not? I may ask a few questions that may point to a brain tumor, but I may need to look at you and see, is one part of your head swollen? Is your eye bulging out? are you talking normally? I need to ask a few questions and those things, look at your behavior and ask people around you who know you to see whether there's something off. And then I may need to request for a CT scan.
Okay.
So if you do the CT scan, for instance, how will I see it on radio? So if you do the CT scan, I may not even...
Okay, it's okay. I think
it's fine. I may not even...
At least I am having it, so...
Never mind. I may not even, see it or know how to read it, but there's a specialist for that. So someone like Dr. Anna, for instance, specialized in radiology. So she specialized in Dr. Nana Ferry's wife.
Okay.
So she may know how to read the CT scan and read it well and tell me that, maybe I may just see a tumor. Okay, this one is just a tumor, but she can read it very well and say, okay, this maybe it's a glioblastoma or something like that, has so and so around it. So maybe there's an edema or something. She can read it into detail and give me a proper diagnosis. I may have just a general. So you need to be seen. So I personally don't believe in e-health.
Okay.
But there are people for whom it is working for. If you go to the hospital, one thing I'm grateful for being a doctor is I don't have to go and join a queue. I can call a colleague, something like that.
Yeah.
So people, and I feel for people who join queues because I hate queues. Even my voters register, I didn't do it because of a queue.
Not at all.
My Ghana card, I didn't do it when they were queuing.
Okay.
I just did it last week. During the mop-up, because I hate queues. So if you don't want to join a queue and you call an e-doctor and it helps you, fine.
Okay.
But once you call and it's not really helping, don't say doctor no abon, because the doctor has really not seen you. You can rather walk to a hospital where you get a full holistic thing, and then you can be sure that this is it. If the doctor thinks it's beyond him, he will refer to the proper place. But don't rely on e-health your whole life. It may be good sometimes, but not always.
Okay, so then what help can doctors come in, or you can offer our viewers who are listening to us?
When we discuss topics, when we discuss topics and you you have questions, I can answer them, but I won't prescribe any medication for you. Okay,
so we don't prescribe medicine online?
Yes,
because you have not seen the
and
person.
I won't diagnose online.
Yeah. Okay.
You can tell me, I can say maybe it's this or that, but most of the time if you say it, I'll let you go to the hospital rather. Because it's not the best for me.
I think this is good. This should help our listeners and viewers know that we are doing an authentic here. We are not, because we want everybody to come and listen, we'll go against your rules as a medical officer. And I think this is good. And I believe that if we can take this advice that, okay, your question will be answered, but do not expect that I will prescribe medicine for you, so that me tea doctor and doctor nakasi. Yeah, so I think this is very good. This is very good. Thank you so much, Doc. So are we going to see new doctors every week, or what should we be expecting every week on Mondays at 6 p.m.?
Well, I what I'll say is there will be a new topic every week.
Every week, new topic.
But I can't say that there will be new doctors every week.
Okay.
So we'll try and vary it so that it's not one person's voice you're hearing all the time, or one person saying that all the time. Like I said, we don't have jack of all trades anymore. So we'll try and pick people who know more about the topic. So if it's an obstetrician doctor, I'll prefer him to talk about pregnancy than I talking about pregnancy, because it's not my field. I do a bit of it. If you come and you are in emergency delivery, I can do the delivery, but I will not make it seem as if I'm the authority in it. There's somebody who is an authority in obstetrics and gynecology, so they will have to do that one, but not me.
Great. Thank you so much, Doc. I think we are making headway. We've come far. Very soon we'll bring our session to an end. Today being the introduction session, we might not take questions from our viewers and listeners, but I've had this question I wanted to. How long have you been practicing, and can you share with us some of your personal challenges in the health sector and your motivation? What has kept you going?
I've been practicing so since 2007.
2007.
So that's
So 13 years now.
plus 20, 13 years. Yeah, 13.
Oh, great.
So
great.
13 years.
That's
Yeah, I'm
great.
still schooling.
Still schooling.
So, yeah, so 13 years. And then what was the other question? What have been some of my challenges?
Yes.
The challenges are multifaceted. I mean, we have the systemic challenges where you've learned so much and the equipment are not there for you to use.
Yeah.
And or you don't have basically the equipment or the things you need to actually practice that thing you've learned. So it becomes a challenge. You have to keep going back to read or you forget about them. So that is the system, lack of equipment. And then we also have the problem of going to patients' attitude. Yes. Where people don't understand you. I've had one, I always talk about this. There's a patient that, you know, people say, me call doctor, me call hospital, and carry and chair me and those things. So for some of us, our training is more like inform the relatives what is going on, inform the patient what is going on.
Okay.
Part of our training, because for us, you may just be there, suddenly you collapse, you come, everybody is scared. We can't just let you be like that. So sometimes we try to explain what is happening to the family. Sometimes we explain to the patient so that, because your life may just have changed within a minute.
Okay.
So we try to do that. But we realize that there are certain patients that you tell, that is when either the family members will fight you when it's not your fault, or not physically, but as in verbally or something, they might abuse you and all those things. Or they will not understand and they will keep coming back. Once you make a mistake of explaining what is happening to one person, before I realize you've talked to 10 people. So about the same thing. Because this person doesn't want to be the one to go and give the information, or they didn't understand. So one time I talked to somebody and then I made a call. Doctor, see, I'm sorry if you don't say, hey! But that is not what I said. So we have those challenges with people not understanding what you say.
Okay.
Or people misinterpreting you. And sometimes too, you tell somebody, okay, so these are the options. Which one would you prefer? When I hear doctor.
Wow.
And then you tell the person, oh, but that is why we are discussing with you. There are two options. Which one will be more convenient for you? So we have a bit of those ones. Lack of equipment, patient attitude, and then even the health workers' attitude. So even though everybody sees us as yetere, among us too, there's bits and pieces of waging so away, not among the doctors, but maybe sections of, and then nobody really understands their part. So if I need an urgent X-ray right now and I write it, the person may go to radiology and the radiographer may say he's doing other things, so he wants something like that. So we have all those systemic issues. And then what are the challenges? I think basically those ones, and then not also getting drugs readily.
Okay, yeah.
So now that there's cash and carry, somebody is dying and need a medication right now. We are looking for somebody to pay for it. Sometimes we've had to contribute, or somebody may have to take money out of their pockets because they can't just stand there and wait. People bring their people to the hospital and say, Doctor, but the thing is, it's not your private hospital. You can't say. So, and they don't have money, and they are standing there. So sometimes I've had people sometimes even carry some emergency medication so that if the person comes and doesn't have, they can give it to the person. But they can't take it from the family anyway, because once you go also go and say that somebody will go and report you, and I'm buying Ojimisica. So we tend to sometimes buy drugs so that we ourselves, we don't go home knowing that somebody could have survived when you get it. So some of us do that. And of course, I think those are most of the challenges, especially in our part of the world where the system doesn't really work.
So, finally, your motivation. What has kept you going in this field?
Oh, I think for me, it's something that growing up, I always said I wanted to be a doctor. So it's something that I wanted to do. It's something that I wanted to do. I also don't surround or fill my whole day with hospital.
Okay.
Some people go from work and go and do locum somewhere. I tried to break that cycle because I don't think I should be seeing disease, sickness 12 hours of my day. No, I can't do that.
Yeah.
So I relax, and I chose emergency medicine because I don't have to follow the patient throughout. When you are coming, you are dying, I stabilize you, I give it to somebody to finish the work. It helps me with my psyche.
Oh, okay.
And then there's God too, and my family. I have a supportive family. I don't have issues. Thank God for that. And then I have God to. I think when you know Christ, it makes life easier for you. You don't stress too much. So basically, those are my.
Thank you so much, Doc. A doc in Christ, I mean, that is more motivating. That is so wonderful because there was this assessing that doctors, because of what they've learned, they don't care about Christianity and stuff. But
it's not
here
true.
we have doctors, and then we have, I mean, Christ is also part of their life.
We have a lot of doctors who are pastors.
Well, thank you so much, Doc.
You're welcome.
Like I said, this evening, because it's an introductory kind of session, we are not taking questions. But I believe that coming days, we see you more often, and also you help us to know more about our health and then the various diseases and then the sicknesses that are really, making lives very difficult. I think that with my health, my life, we shall have more comfortable life.
Hey, now we are the CCR Ghana Radio.
So God bless you for being with us this evening.
Amen.
And I can assure you that every Monday 6 p.m. when you join us, you will never waste your time. Health issues are important, and that is why you need to be part of my health, my life. I have been your host. My name is Francis Masai, and see you same time next week, Monday at 6 p.m. But for now, we say, take very good care of your health, especially this time of coronavirus. Please make sure that you observe all the protocols, all the necessary things that the health service and also the government have asked to do. This is his word. We want to take the last words from Doc, and then we wrap up our time. Doc, so any final words for us? Monday as is 6
So what I'll say is,
for now,
we pray that we'll be able to give you a lot of information about your health, and then answer all your pertinent questions. We'll try and cover the commonest diseases that people usually struggle with. So try and tune in to my health, my life.
Thank you so much.
It's his promise. In Exodus 15, verse 26, he says, I am the God.
God bless you all, and we'll see you same time next week, Monday, 6 p.m. But for now, it's bye-bye.
And healed us. The Bible says his word will not return void, but it will accomplish the purpose for which it is sent. God's word in the name of Jesus is more powerful than cancer, heart disease, or any disease that you can name today. So let's put his word on our lips and let his healing come to us.